just giving me. All right, well, it's recording my words, so I guess I am recording. Okay, so here we are in March for the How to Succeed as a Reviewer series. We're going to talk about homebound status today. So this obviously speaks to the OASIS reviewers out there, but if you are a coder, that is something that you want to be sure of, that you're looking at a chart to make sure this patient should indeed, be an active patient. Last thing you want to do is be coding a whole chart and then we get it back saying, this patient was not homebound. What are you doing all that work for? We're not paying you for this chart. You should have returned it. So it is kind of everyone's responsibility to make sure that homebound status is indeed being followed. I cannot get the screen out of my way. Okay. So we're going to talk about, obviously, CMS's statement of homebound status. And of course, homebound does not just apply to your Medicare folks. It applies to anyone that per their payer is required to be homebound. And some of them that we know really don't have that requirement is most Medicaids do not have that requirement to be homebound, but even some do. So you always have to be aware of that, or at least the clinicians and the agency should be aware of who really needs to follow homebound status. We're going to look at the criteria 1 and 2 for this, your guidance and your examples for documentation surrounding homebound status. What we would like to see coming from the clinicians will also be covered. And we'll also look at just example or 2 of claims denials regarding documentation, which is actually one of the top 5 reasons why charts are denied is because of documentation surrounding homebound status. So just to start off with, people will just say, our folks have to be homebound. Okay, but they can leave the home. Absences are allowed if there's a taxing effort where it's deemed to be infrequent or of a short duration when they're leaving the home. They can go out for religious services. What I would say to that is, church once a week, mass every morning at 6 probably might get a little attention on CMS's part. Like, wait a minute, if they can go out every day to morning mass, then somebody can be taking them out for outpatient care somewhere. They're allowed their occasional trip to the barber, get their hair done, walk around the block with assistance. And again, I would watch the documentation surrounding that. What kind of assistance? Really walking around the block? Okay, let's just make sure this patient is indeed homebound. They can even drive. They're allowed to drive. If they live alone, they need to go out to get their food, get their meds, whatever the reason. If there's a really good reason why they have to be driving, they can drive. But again, that documentation has to support that reasonable and taxing effort caveat. So they can go to family reunions, graduations, funerals. As long as the provider is saying, yes, this patient can go out, the patient can go out. Again, those short, infrequent trips. Adult daycare.
Hey, Arlen, for us old people in the back that can't see good, can you make it any bigger?
It's on my full screen.
It's real tiny, and you got a big background. It got tinier, you got bigger.
All right, let me change this because I've got just a weird view showing here on my computer.
That's better. That's better.
Okay, that's better. Okay. I'm like, I've got this white box that popped up on my monitor and I cannot figure it out. I tell you, me and Heather today, we're just having issues with this whole thing. But okay, so that's better. All right, good. All right. Okay, so they can go out to adult daycare. They can obviously go out for the dialysis. You can't tell someone they can't go out for their medical treatment. Outpatient chemo, radiation, all that's fine. So again, short duration, infrequent events do not cancel someone's homebound status, but we have to be sure the documentation is supporting the effort involved and how they just can't go out willy-nilly on their own and just go playing around the Walmart lot. So the rules, homebound rules per CMS. The patient shall be considered confined to the home if the following 2 criteria are met. So to me, this is actually 3 criteria. So on the left, we have criteria 1, where they say one of these must be met. So we either have item 1 or 2. 1 is the one we're most familiar with. Because of illness or injury, the individual needs the aid of something, some kind of device or a person in order to leave the home, right? Or 2, they have a condition such that leaving the home is medically contraindicated. And this one got pulled a lot during the time of COVID. That was a lot of the reasons for why someone was deemed homebound. Because of the COVID status, the physician did not want them leaving the home. That was not used as much as we're trying to hit everyone on criteria 1. Once criteria 1 is met, then you move on to fulfill criteria 2, which means if we could not, the clinicians, if they could not get the patient to meet criteria 1, they are done. They should be leaving the house. Say, nice to meet you, but you do not qualify as homebound. You don't even move on to criteria 2. If you can't pass 1, you're done. So if you do pass 1, then you go on to 2, which actually has 2 parts to it, which both must be met. So this criteria 2 says 1, there must be a normal inability to leave the home. How great does that get? And 2, leaving home must require a considerable and taxing effort. We all know these words, right? That's all we see. So
Question, we have a question. Is it true the patient can go to adult daycare, but home care can't be provided there?
Right, we can only work in the home. We cannot work at someone else's site because we are not employees there. But they can go out to adult daycare and you see them afterwards when they come home.
Going back to the COVID, the allowance for the patient to be homebound because of COVID or their risk of exposure, is that, I'd have to go back and look. I read it the other day, but don't remember. Is that ending in May also? Do you know?
Oh, I don't know. With the PHE, I don't know.
I just say that's
just the clause they pulled, in order to keep these people that were obviously physically able to just get up and leave the home, but the provider did not want them being out amongst the unwashed.
I'll go back and look, and if that's ended, I'll just put it in the chat for this.
Yeah, I mean, there's a lot of things that are going to change when the PHE ends, and that's a job for Heather to take on. How's that view from under the bus? Okay, so homebound documentation, what we want to be looking for when we're looking at how the clinicians are documenting homebound status, which does not mean they're checking off boxes and moving on to the next item. And this is where it gets a little sticky because agencies are terrible at documenting homebound status, generally as a thing. So we want to look at the time of admission or restart are all the reasons why the patient can't just up and go, and all the contributing factors should be noted, right? Is everything being checked off and explained? CMS wants to see from that clinical perspective how the patients meet that criteria. So if you checked off a box, what are you saying about the patient, why you checked off that box? And I used to, when I teach the OASIS class, when I get to the homebound status part, and I'm like, I know you all have whatever EMR where you're checking boxes. Think of every box that you're checked has at the very end of it an AEB, as evidenced by. What's your documentation going to say? You said they have a reasonable and taxing effort to leave the home, as evidenced by. What does the patient look like? What are they doing that you chose that box to check? And I think that every EMR should have that on there. That now you have to fill it in, explain yourself, support that answer. When you're reading the documentation on homebound status, there should be no question that the patient cannot and does not leave the home readily, right? There has to be some type of safety aspect to it maybe, but really the documentation should be supporting that this patient is indeed homebound. The OASIS data must also serve to substantiate the homebound status, especially, of course, the functional limitations, the GG items, the M18 items, right? If you're saying someone is homebound because it's a reasonable and taxing effort and they need someone to help walk them safely, and then you go and score in the GGO 170 items for ambulation, that they're independent on everything, not making sense. Did the clinician relate the homebound status to a diagnosis to support the home care? And that could very well be. And that, again, would support some of those. They can't leave the home because there's some illness or something that the provider does not want them leaving the house. So where does this all come from? Who says? I always like to, point to this. This is where you see it. It's not just my opinions. Your Medicare Benefit Policy Manual, Chapter 7, which is, the Bible of Home Health, Chapter 7, in Section 30, the check boxes, this is what it says. they're not sufficient to support homebound status. And this is their actual words right there in quotes. The clinician is not required to include standardized phrases reflecting the patient's condition. So those standardized phrases is what they're referring to as, we see what the EMRs have put in as the checkboxes. Those are called your standardized phrases. And CMS is saying, right, the clinician is not required to say those things. As a matter of fact, such phrases by themselves don't demonstrate that the criteria has been met. So what they're saying is, don't be repeating my words back to me. Don't just tell me it's a reasonable and taxing effort and then move on to, okay, are there any fire extinguishers in the home? No. Go back and tell me how it's a reasonable and taxing effort. I don't want to hear my words coming back to me. I want you to tell me what you see on your side. How does the patient support that criteria? So the checkboxes are not sufficient. So with this criteria 1, again, documentation needs to be present that supports any of these items checked, whether it's they need assistive devices or special transport or a human to help them out, or do they have some type of medical contraindication. With the criteria 2, these are just things to consider, if the patient's bedbound or wheelchair bound, the assistance, the different medication issues, the different diagnosis issues. So all these things can be considered, as contributing towards their homebound reasons. So sometimes it might take a little dive into the documentation just to make sure, if you get that little squirrely feeling on the back of your neck saying, I'm not sure this patient is homebound, and the clinician has not really described it well for you, can you find anything that'll really support it in the documentation or in this patient's medical history? So any of these would be, ways to cue your mind of what to look for within the chart. On component 2, now we're talking about things being a reasonable and taxing effort and what affects, what brings on that reaction of being taxing. And from a physical standpoint, we're talking impairments. And that can be related to any of the body systems with the patient, not just the muscular system, but, do they have impairments across any other body systems? And the same thing with functions. Do we have a dysfunction going on in anything that, you're trying to enact movement to get someone out of the house. And if you have a dysfunction, that's going to make getting up and leaving more difficult. So again, you just want to consider, let's take a look at what's going on with this patient in their impairments and in their functional disabilities. So we've seen, you can pull this up on any, the CGS, the Palmetto, NGS sites, the top 5 reasons for chart denials. And it's always fun because it's basically the same stuff every single year. And one of them is always homebound denial reasons. And they say flat out every single time, documentation either doesn't support all the homebound criteria, because you can't just support one, you've got to support all the homebound criteria. Doesn't support that there's a normal inability to leave the home or that there's a considerable and taxing effort. And again, if they just see the boxes checked, unfortunately, they're going to have to start diving into the chart to see what more they can be found. And like we say, we never want to get Medicare's attention looking through a chart. We want them to find exactly what they're looking for really quickly and leave the chart alone, right? They start digging, it might not get pretty. So there's a denied claim out there. For instance, it says the documentation was patient is no longer able to drive. There's a taxing effort to leave the home and requires a cane and another person to do so. Okay. So what CMS came back and said was, well, nice start, but the documentation should describe what the taxing effort involves. It is more than just needing someone else and a device. You need to talk about that shortness of breath after exercising, any mobility deficits or increased pain with ambulation. Why do they need the other person? Why do they need the cane? Trust me, anyone using a cane or a walker isn't doing it just for kicks and giggles. Most of them do not want to be using a device because they think it makes them look old. So if someone is actually using something, there's a reason for it. So document it, right? So we should be seeing that documentation. We should be demanding to see that documentation. That documentation should also present enough information that the reviewer, us, right, you guys, is certain that the patient's taxing effort qualifies. So the accepted claim, and they said, this is what we would like to see. I'm like, okay, that's a lot of words, but clinicians can type. The patient is not safe to drive due to her multiple medical problems and history of several automobile accidents in recent months, to which I say, take the keys. She cannot obtain reliable transportation. In her current condition, she becomes significantly short of breath with even minimal physical activity, and this makes travel outside the house very difficult and taxing. So if you actually see a wonderful statement like this, first thing I'm going to do is I'm looking at M1400 and then her GG items and the M18s to make sure that all of that verbiage is backed up with her ADLs. But that in itself, I look at that and say, no, okay, she's homebound. I'm not going to have a problem.
And that's probably a scenario that somebody made up. If you say that kind of that good documentation, especially in complete sentences.
Yeah, especially in complete sentences. Yeah, and it wasn't that text verbal to text, because you need some interesting words there. Yeah, so and this is this is one of my favorites from a chart. I said we have a beaut here. So then all the M18 items all marked as independent. The GG items, again, all marked as independent, except that they said for the 4 to 12 stairs, they marked this patient as a 10, not attempted due to the environment. Okay. Homebound status, again, they're just checking off stuff now. Needs the assistance of someone else to leave, requires the assistance of another person, unable to tolerate community distances, unable to leave home without considerable or taxing effort, and decreased strength and endurance. And then you go over to this other section within their EMR where it talks about assistance in the home environment. And apparently there's no structural barriers in the residence. They're not an issue. Structural barriers are stairs, by the way. They live alone. The frequency of assistance needed, I don't require assistance. And you just told me in the homebound status on the left that they need assistance of another person. So, yeah, you just got someone's attention, willing and available caregivers. Well, there are none, which could be someone's misunderstanding when you have that patient that lives alone. Just because they're doing things independently does not make them safe. Right? You are allowed to leave unsafe persons alone in their home. That is their choice to live alone. Definitely want to bring in social work, but it's okay. So I don't know if this clinician was thinking, well, I can't put that they don't have caregivers and they do or don't need assistance, so I'm just going to make this patient look like they're okay. Well, no. So you don't say they don't require assistance because they don't have any. It doesn't work that way. Assistance available, there is none. All right, well, again, so that's an issue. But their part of the EMR where they filled all this in is contradicting with what they put as the homebound status, which is definitely going to get someone's attention when this chart gets dropped somewhere. And it'll probably get sent back on an ADR or flat out claim denial saying you need to take a look at this homebound status, try and refile, or you're going to eat this episode. So, like I said, I didn't have a lot of slides on this because there's only so much you can say about homebound. But so that gives us a chance to, chat a little if you want. Or not.
I just say, going back to what you talked about, what they may be doing in the home that's unsafe. When I was new in home care, that was a very hard concept for me because just like you said, I thought if I walked in that house, that patient had no caregiver, she was holding onto the furniture and, those impending falls and that sort of stuff, that if I marked patient needs assist M1860, I made it a 3. But over here, I said they didn't have a caregiver, and I walked out of that house. Then to me, I was documenting negligence that I had not addressed.
Yes.
It's exactly what I felt like. And it took me a long time to get past that.
Yeah. Yeah. And the funny thing is, this isn't really funny, but all the nurses will agree totally with you. The therapists were like, yeah, whatever. It's your choice to live that way. We'll make you better. But it's just, it's the mindset. And like I always say, that's their choice to live alone with that, knowing that they have those disabilities. Not that they have a disability, that they have those disabilities. And that's why we're in there to recognize what is wrong and we need to make it better so that they are now safe in the home. You know, if we went out and everyone said, you're not safe to be here, and said you have to go to a nursing home, there'd be nobody in home care. We'd have to put them all somewhere for a while. Unless, of course, you know, they live with someone, but there's a lot of people, mostly women, that are living alone because they're outliving their spouses.
Right. I think what we can do as auditors is when we send those correction notes back, whether it be on M1800s or GGs, that we make sure that our note reflects, because I'm bad to just, you know, put it quick down there based on this, this, and this. Put a little bit, don't copy the guidance for goodness sakes, because then your note gets so long nobody wants to read it.
Right,
but just
right.
make sure that we've got enough verbiage there that maybe they're starting to understand
Right.
that what we're talking about is safely. And I always, when I teach an OASIS class, you are making some inferences when you're looking
Yes.
at these items, because
Yes.
you're not looking, okay, this is what they're doing, this is what I'm gonna mark. So I think that's hard for us that have always been, anybody that's a clinician that's always been taught, you document what you see,
Right.
you know,
Right.
as objectively as possible. So I think that may be part of the problem for a clinician why it's hard, but I think we can probably make sure that we have enough verbiage that maybe they're kind of getting the gist of it. And over time,
Right.
it'll sink in.
Right. Right. And basically, you know, it could just come down to, you know, just as simple as be sure you have documentation that supports your homebound check boxes.
Right. And Heather
You know,
might have brought up a good
yeah.
point about psych patients, because
Mm-hmm.
I don't see it much, but we still have a few people that have psych. So
I think they had some, I think we've got one contract that I had heard that was primarily psych, that they keep on seeing psych, psych, psych. So
Right.
I wanted you to expand on that. I'm so glad you can actually hear me.
Yeah, I am too. It's nice. As
Great.
opposed to this morning's conversation.
Yeah.
Can you hear
Yeah.
me now? No.
Yep, yep.
Yeah, the psych, and that the psych might be one of those conditions that the physician does not want them leaving the house by themselves because it might not be a good thing. You know, let's, you know, look at your Alzheimer's, even if that's the psych diagnosis. Do you want them out on their own running the streets? You know, no, no, no. Or, you know, your other psychoses, depending on their level and their condition, you know, they might need that supervision all the time. So again, you're going to have that medical condition that deems them to be homebound because it's just not safe for them to be out on their own. I don't know if we ever see anyone in home health that's that far along on the psychosis spectrum.
I don't know.
I don't
Sometimes
think
you have
I've
those
ever
people
run
that
into
have.
someone that was that far along. You know, I've seen some schizophrenic patients over the years, but
Yeah.
Yeah, we've
Yeah.
got a whole agency that does ALF psych.
okay,
And
Yeah,
so
well,
they do
yeah.
a lot of home health for like long-term injections.
right,
Right.
So they're
Yeah.
homebound due to, you know, anxiety, unwilling to leave the
Okay.
home, and some of them
Yeah.
are more severe.
Are they in locked units?
Some of them.
Yeah, yeah. If they're in a locked unit, there's a reason for that.
But then you have
Exactly.
those that have, what do you call it? Agoraphobe. What do you call it when you're not, that's spiders, I think. Whatever it is that you're that
Afraid to
fear
leave
of
the
leaving
home.
the
Yeah, it's
home.
agoraphobia. Yeah, yeah. That
Our fear of
Perfect.
spiders, I don't know if they're in the front door, you wouldn't leave the home. Either way, it could work. I'm not a psych nurse,
arachnophobia,
thank
right?
God. I'm much closer to a psych patient than I am a psych nurse.
Amen, sister.
Yes.
Aren't we all?
Aren't we all? Absolutely. Absolutely. I know by about 2 o'clock on Friday afternoons, I'd qualify for brain dead. Just one notch above the coma scale. But yeah, so you know, I would just, you know, be sure if you're seeing, you know, one of your agencies getting a little sketchy on their homebound documentation, I'll just, you know, nudge them a little just to, you know, get them back up to where, you know, it's really acceptable documentation and make sure that they're really being clear to support the check boxes. Because check boxes are not sufficient per the Medicare benefit policy manual. So that's always your fallback when they say, well, says who? It is right there in that section 30.1.1.2 or something to that effect. But it's right there. You cannot miss it. You know, like I said, this is not an old wives' tale. It's in black and white in our home care Bible. All right.
Well, thank you, Arlen.
Thank you. And
Hey, Heather, you want to show your face and introduce yourself right quick?
that'd be awesome.
Well, I can, but I